All right, we're live. Hey, hi there. Welcome to the second in our series of 8 blog and live Q&A sessions. My name is Matt Bobman, and I'm really glad you're here. Before we get into today's live Q&A, I want to take a second and remind everyone that our past live Q&A is up at the blog site, along with Dusty Grooms and Lindsay Lepley's great post. Lindsay also circled back and put together a 2-minute rebuttal about open chain knee extension and mechanisms of eccentrics that you can see there as well. So please check it out if you haven't already. I also want to remind everyone that we have an 8-hour online course that features Claire Ardern, Rich Willie, and Dustin Grooms. That one's called the Home Sessions. You can find that at our site, as well as registration for the upcoming Evidence and Practice ACL course. That's going to be going on May 22nd. And that's a comprehensive ACL course. It's set up as a pay what you can price, because I know that some of us are still hurting from pandemic restrictions. While doing this project, I've had the privilege of organizing a few courses focused on ACL rehab, as well as connecting with loads of excellent educators. This blog series is an extension of that, and I couldn't be more excited to sit down and talk with the authors of the most recent posts. So I'm happy to welcome Meredith Chaput and Harjiv Singh. So thank you guys so much for taking time to write the post and now sit down with me and answer questions about it.
Yeah, thanks for having us.
Yeah, but before we get started, before we get to the questions, I was hoping you guys could each give us a little bit about yourselves, what your PhDs are all about, and we're just curious about how the pandemic has affected your research.
Meredith, do you want to go first?
You can go.
Okay. Hi everyone. I'm currently a third-year PhD candidate here at the University of Nevada in Las Vegas. With Dr. Gabby Wolf, and my research looks at how attentional focus interacts with the development of skilled performance. And in terms of the pandemic, it's been quite a year with very little to none research, but it's been a year where we really invested ourselves in what's out there and really kind of hone in on what needs to be done. And glad that we're starting back up now with a lot of PPE equipment, but it's different. But I'm glad things are coming back to what we had before. So it's an exciting time.
So my name is Meredith. I'm starting my second year. Just started my second year in the PhD program at Ohio University with Dustin Grooms as my primary mentor and Janet Simon as my secondary mentor. And I primarily study cognitive control of movement, and I'm specifically interested in vision and how visual attention impacts movement and in athletic performance in general. I started my PhD, and then 6 weeks later, the pandemic hit. So my in-lab research has been very minimal over the last year, but this semester we've been very fortunate to have been getting back into the lab more and getting pilot testing going and all that kind of stuff. So we're finally have the ball rolling, and it's good to be diving into in-person research again, for sure.
It's great. Yes, it's threw a wrench in everybody's lives. I'm glad you guys are still making progress. Okay, well, we got some really great questions. We got like 20 of them. So we're gonna get going on those in just 1 second. But before we go do that, I want to put you guys on the spot, and I want to ask for some definitions to start us off, because I think, like, I'm a clinician, and I don't deal with this type of language every day, and so starting off with just sort of a foundational understanding of what some of these terms actually mean, I think would be really helpful. So I'm just gonna get a brief definition for each. So what is motor learning?
Yeah, that's like the golden question. Essentially, motor learning, when we think about motor learning, we think about the relatively permanent sort of change in one's ability to execute a motor skill as a result of practice or experience. And so you see a lot of like retention and transfer tests that happen to really understand if this individual has learned the task or relearned the task. So that's pretty much the definition, I think I'm more than happy to post some slides together for you in more intricate definitions and resources that listeners can go through. So.
Maybe we get a 2-minute webinar style video to post on Twitter after this. That would be great.
Yeah, for sure.
Okay, so what's motor performance then?
I guess I'll take that one again. Essentially, so we had motor learning, and in contrast to that is motor performance, which is just the act of sort of executing that motor skill. And that results in sort of like a temporary, non-permanent change. So can that person do it then and there? So I think Meredith is probably a better clinical perspective to that.
The way I like to think of it is motor performance from a clinical perspective is probably like how well did they perform in your session. So if you're working on a squat jump, landing task, did they improve their motor performance in that session based off of whatever standard you're using, whether that's valgus collapse, landing softly, however you might measure that clinically. Whereas motor learning is what is my retention? Exactly what Harjiv just said. Can I do this 3 weeks later, having not practiced it? Did I retain those skills and the knowledge needed to complete that motor task?
And how do those contrast, like motor control or motor behavior? Are those separate terms, or are they variations on those two?
So motor behavior is the overall big term, and then you have motor control, learning, and performance. And control is just, we're looking at the mechanisms behind all of this stuff. So that's an easier way to put it. But the motor behavior in general is like the big name.
Okay. And then the last, there's more, but I think I'll just add just one more for my sake. What is attention? How would you define attention? Both of you study it.
Yeah. So attention, honestly, we have no idea what attention is. It's something that we talk about it a lot. And I think the definition for that is still kind of being created and discussed. But in terms of the motor learning literature, we look at, what are you concentrating on while you're performing the set skill? How are you concentrating on it? Where are you concentrating on it? So those types of questions. So, for example, are you concentrating on something related to the skill or not related to the skill? Are you focusing internally or externally? Are you focusing closer to your body or farther away from your body? Those are the types of things that you'll see a lot in the literature.
Okay. Just to go off that a little bit, in the visual space, people like to think that visual gaze or what you're looking at is what you're cognitively attending to. And those two things can be very different. So that's the other thing, just kind of keeping in mind the rehab component of it. When we get a little bit further into this discussion using a visual task or something like that, what you're staring at doesn't mean that you're attending to it. I'm sure Harjiv can go on for a lot longer.
Yeah, story for another day.
Yeah, well, great. Well, thank you for defining those. For everyone who's watching out there, if you have questions about what we're talking about or something pops into mind, please put it in the chat or the comments. I will do my best to monitor Slido, but I may miss something if you put it there because I've already gone through it all. So please put anything new that comes to mind on the chat function. If you're feeling sheepish, I'm going to put my email address in the chat, and you can email me a question if you don't want to be public or whatever, or if it's too long for the box. So I just posted my email, so please email me. Okay. All right. So let's get into questions. I think the first couple go together. Well, let's see. The first one is, what do you think rehab will look like in 10 years or 20 years? Will it be vastly different?
That's you, Meredith.
Honestly, I think orthopedic and sport rehab is going to look a lot like neuro rehab. And learning that all of the skills that you learn in PT school from your neuro classes, such as motor learning, stroke recovery, using cognitive loads, dual tasking assessments, all of those things are going to become more well accepted, more well integrated into whether it be performance training in rehabilitation interventions throughout the continuum of care, but also in return to sport assessments, as we start to understand a little bit more about how all of these things are just a piece of the puzzle to optimize performance and overall function in rehab.
Yeah, just to kind of go off of that, I would be a little biased and say in 10, 20 years, a complex systems approach would be adopted in rehab. So please read the blog and yeah.
Nice. Well, I will point out that some of at least one of your references is from 1956, Brunswick. So that's pretty old. That was a long time ago. So are we catching up, or is this? Are we seeing hints of this being the standard? But that was 60 plus years ago.
Yeah. It's so. One of the things that I've made sure I did in my PhD is really understand where the field was to where it is now. A lot of it actually had to do with, back in the day, we were very like cognitive heavy, right? It was very information processing heavy. So the work of Brunswick and Gibson and all that, they were just not looked at. People just didn't care. Now, as we come into today's world, we have people translating works into English. We have now people actually, looking at all these old sort of resources. I mean, just in the motor learning realm, the big like Schmidt schema theory, right, that came out in the 1970s, but Gibson's and work in ecological psychology was way before then. Why is it that there's the timeline difference in terms of why didn't we know about Gibson, right, until like essentially now, where it's really gotten into the mainstream? But there's a lot of politics essentially back in the day that disallowed it, but I think now we're really trying to understand it, which is fun. So
have there been any studies that investigate the use of these concepts in musculoskeletal rehab? I know there's been some Delphi studies in ACL rehab, but I don't know if this was something that was looked at.
It's been not really. I think we need more. Meredith's probably a better answer to that.
No, I think that that's the interesting part, and that's where this is going. Is a lot of this and like the motor learning theory is based off of skill acquisition, and it's really transformed coaching, sports coaching, and that's who has really adopted this first. But what's interesting and what I find most interesting is that the theory to me is applicable in many ways and makes sense. Like it's just like, oh, intuitive, I should probably train this way, but the research hasn't been there. And we have to realize that when you're dealing with such as like a ACL injury, your sensory motor system is no longer intact. So we need to understand how motor learning occurs with a sensory motor system that isn't intact, right? You have this new graft that doesn't completely recover proprioceptive or somatosensation input into the sensory nervous system. So how does the body need to change and adapt to maintain performance with this alteration, right? And I think that's the intriguing part of this for me, is we know that these sorts of interventions can really improve motor learning and skill performance, but it's how do we get this into rehabilitation? Yeah. And then do we understand the mechanism behind it when your sensory motor system isn't completely intact?
Yeah, just to quickly add on that, I think even like I think there was one question regarding this, but even like this idea of what we're learning, I think PTs are and clinicians are very much into the what to do, and I think the motor learning end of things allows you to kind of have a basis on how to do things and how to do it more optimally and better. So I think the marriage between those two, I think, is really critical. And like Meredith said, I think it's getting there now, with especially with the work of Meredith, Dr. Grooms. I mean, there's a whole bunch of people that are really trying to adapt this motor learning stuff up.
Yeah, I mean, from a clinician standpoint, I think it needs to be more integrated into PT school. I think I got a half a semester motor control, half a semester motor learning class, and I think it shouldn't be a separate class, and it should be part of your orthopedics and therapeutic exercise.
I felt very fortunate as a PT student because we had a motor control, motor learning class. But then when we were in it, it was a fantastic course, but everything was neurologic rehab, right? We talked about Parkinson's disease, we talked about stroke. And as a PT student, at that point, when I was taking the class, I wasn't able to integrate, like, what is my information and how am I applying that outside of this classroom to the populations they're individually speaking about? And Kerry Grindstaff at Creighton actually told me when I was a student, he was like, I know you want to do sports rehab. I know you want to do residency in it. Go do an outpatient neuro rotation. You will not regret it. Go do an outpatient neuro rotation. And it was probably the best thing that I did in PT school, because it opened my eyes to what I was kind of missing and applying into my clinical practice in sports and ortho.
I'll also just say this is that I think schools are making the attempt to add in like movement science courses, and I honestly think motor learning should be something you do every semester, every year, for every single topic that you learn. But that's just my opinion.
At all.
That's not biased, but I think also when I look at some of the curriculums that PT schools are using, they're very much old in terms of the principles of motor learning that are being used. Like I said, you may talk about Schmidt's schema theory, but that was like over 25 years ago. There's so much more research now that you can actually, change. And so it's, and then you kind of get stuck in the whole blocked and random practice, which again, I think is misinterpreted, but it's, I think the upgrade needs to be there, but that's just,
Yeah. I think maybe you guys should write the next textbook. Me too. All right. So here's a good question. Is a lack of constraint, movement, goal interaction one reason why movement screens like the FMS are not as useful as we'd like?
I guess, Meredith, you got that one?
I think movement screens, personal bias here, such as the FMS, they're not injury predictive. We know that through our research that we have now, right? Without motor learning or taking that into consideration. They're very isolated. And so being able to hold the dowel over my shoulders and step over a bungee cord is going to look at coordination kind of, or like shift to single leg and, do I have hip range of motion to complete this specific task? But there's no like end goal to it. And there's really no application to a movement that you'd have to do in sport either. Yeah. So I think just the general application of movement screens such as those, they're very biomechanical. They look at your range of motion and your coordination, quote unquote, to do a very specific task. That does not relate or integrate any sort of the environmental things that we talk about in our blog of having to constrain to factors and such. So I think that they're limited by what they're created to assess. They're made to assess biomechanical variables, and that's exactly what they assess.
Yeah, I agree 100%. Yeah.
Okay. So what's the balance between self-organization and injury risk? In other words, is there a time limit to how much, is there a limit to how much movement variability should be allowed?
Yeah, there's always an optimal level of movement variability. And I think, again, if you go over like I think the way that clinicians can actually track these things is very longitudinal. Like, there's a lot of information that's needed, and the research in this realm is really low. And there's a lot of different methodologies you can use in terms of analyzing whatever data that you collect, but that's just extra work, right? Are you willing to do that in the already limited time that you have, right? That's another question for another day. But I think the best place to start is go back to the basics. Is the patient able to do whatever you're being asked in a safe manner, right? Safety is the number one concern. Are they able to do it? Are they able to retain it, transfer it? Regardless of what approach you use, at the end of the day, it has to be safe, right? I mean, yeah, you have to have it so that you decrease the ability to get hurt again. So that's probably what I'll say is there's, I'm more than happy to send whoever sent that question methodologies and papers that actually, really list out the way to analyze it. But I think that would probably take another hour and a half. So,
well, I think that going off of what you just said, Harjiv, I think optimal is the strategy there. So like our biomechanics data that we have, there's a window of, yes, this person is potentially going to get injured if they have this much valgus collapse or land with this much knee stiffness, etc. But I think when it comes to rehab, we get so funneled in and focused on it. And so we try to put everybody in a box of perfect movement. And we don't allow people to explore their own variability and make errors in rehab. And the basis of motor learning and learning new coordination is by making mistakes and errors. And so if we minimize that in rehabilitation and we don't provide them the opportunity to mess up in our very safe environment, how is that going to translate to sport? They're going to do whatever their implicit natural strategy is primarily. And then most of what you probably taught them is going to maybe not transfer over. And I think that's the disconnect we see. Where, like, I can train somebody to do my box jump really well with their perfect knee alignment, not over their toes, no valgus collapse. But I don't train the system within their available range of motion to correct for that error when they get out on the field.
Yeah, and just based off of that point, I think a more clinical perspective is people probably heard of like bandwidth feedback, where you take that whole bandwidth and kind of incorporate it into your actual movement. You want to basically have that bandwidth of obviously safety zones, but again, like Meredith mentioned, in the different range of motions, and as you want to create these adaptable individuals. So the way you do that is through sort of not the one size fits all, but like the multiple sizes fits all situation, So yeah.
A couple things come to mind. The first one is that as a clinician, if you're in a gym and your other PTs or other staff are not, they can tend to give you funny looks when you're having a patient struggle with a task. And I think the obvious thought that comes to them is, well, that patient's not ready for this task because look how poor their technique is. And I think that's an error on just sort of the clinician's foundation of how they want to train people. But it does make it kind of hard to like take people out to the gym and try these new movements or progress them or whatever. So there's kind of some social pressure to pick movements that look nice. Yeah, I'm making a list of all the extra webinars we're going to do. Yeah, go ahead.
I touch on that? I think that is such like a solid point that you just made, and like this is external to the blog, but the pressure or social pressure that occurs in the clinic, and this isn't even just about letting people have variability in their movement, like you used as an example, but like we were literally talking just earlier today about how social pressure of like maybe not doing like NMES early because you're afraid of, you don't really know how to use the unit, right? Or like not everybody in your clinic uses it. So when you bring out the unit, like everyone's staring at you, like, why are you doing it? And I think that that's a cultural thing and a clinic thing. And so it's important to create environments that are appropriate for learning as a clinician, but also your patients, and promote those environments. So I would encourage people to be the clinician that others are kind of side-eye looking at, because you want to be progressive in your interventions, right? And you want to be able to show the people around you how you're being progressive in them, and be that leader in that force rather than being hesitant about doing them.
Yeah. If you're not getting side eyes, you're not doing it right.
That's just my personality, though. I don't know.
Yeah, that's good. And so, Harjiv. So another thing that came to mind was I was thinking about this movie Free Solo, where this guy, free climbs up El Cap, and he mentioned, he was talking about fear, but basically, and I was thinking about bandwidth here, and he was saying like I do something that's scary, and I keep doing it until I'm not scared of it anymore, and then and I grow my comfort zone, and I thought that was
that's exactly what it is. I think you want, and that's what variability is, right? Like you want to start off with essentially you want to meet the limits of what the person's optimal variability is, and just like that, creating that bandwidth through different exercises, different instructions, different approaches. I think again, we talk about rehab, the whole point is, is this person able to retain and transfer said movement pattern? So I think, again, that bandwidth area is important to consider.
So the next question is asking to expand on two concepts that were in the blog. So the concepts are motor skill learning as discontinuous changes over time, and motor learning is not a linear trajectory of improvement. Can you kind of talk about those two ideas?
Meredith, do you want me to take this? Oh, yeah. Yeah, so motor learning as sort of discontinuous over time, I think, like we hit on it a little bit in the blog, the whole linear and non-linear stuff. But so when we think about linear, right, we think about like proportional, right? If I spend twice as much time doing something, I'm going to get twice as good at said whatever I'm doing in terms of the predictable outcomes of learning. Now, for a nonlinear approach, learning is very erratic. There's sudden progressions, regressions in performance, plateaus exist. So practice kind of results in like multiple unpredictable learning outcomes. So it's like a shift from thinking, right? The current sort of approach, and you probably learned this in PT school, is like the Fitz and Posner model, right? It's like you want to get an idea of the movement and then kind of progress from easy to hard. But this whole nonlinear or discontinuous approach is like saying that, look, our motor system already has the capability to self-organize such that there are just different covariations of different levels, muscles, joints, you name it, for a stabilization of whatever sort of performance variable there is, such as like jump height, for example, right? That you don't need to go from, let me get an idea of movement, to then getting harder to harder. It's like, it's there that we're able to do things. We have to find, essentially as clinicians, find what is the most appropriate, zone for them to actually perform that task. So it's just a shift in thinking at the end of the day. Again, a lot of methodology behind it, but there's that's what I would say is to answer that question.
That's kind of hard for a clinician, because you like to see a nice steady progression. You like to be able to write a note and document that last week they did this and this week they did this, and this is how this is why you should continue to pay me for this service. So
no, I agree. I think it's really hard. I mean, I don't, how to apply it is, I think you have to be really creative. That's essentially what the answer to the question is. I'd say the application to it is a whole nother ballgame. And that's something that I'm still trying to learn and figure out. So I don't know, Meredith, if you have a better example.
No, I thought what you said was perfect. And I think understanding this concept was the hardest thing for me when I was in residency, was because I noticed that I would give so many cues with so much feedback, right? Because I was trying to promote this linear progression of skill improvement, right? But then I realized that my patients weren't learning, they weren't retaining. And when I spoke less and I gave them less feedback, they might not do as well in that session, or I gave them different feedback. They might not do as well in their performance in that session, but 3 weeks down the road, they were very proficient at what I wanted, and I could add cognitive demand to that skill. And that's another layer of difficulty, right? That's along this kind of nonlinear spectrum. So I guess my mindset is more linear than Harjiv's, right? I was still looking for a performance expectation of, this is what I think you need foundationally as a movement skill. But by understanding that it might take more time to be proficient in those skills by using this methodology, it made me better. And it also really helped my patients learn and actually feel autonomy in their therapy. They felt like they had a lot more control over the situation just by me talking less in the session, right? And because then they understood their errors. They understood when I said, only gave feedback, good or bad, to a depth drop. They knew, okay, this is how I messed up. They were more in tune to what they were doing.
It's just a clinician's struggle. But
you guys have you have the hardest job.
This is why I'm not a clinician. I'm just kidding.
The next question is a clinical question. How would you implement some of these concepts in an acute phase after an ACL reconstruction?
Yeah, Meredith, that's you.
I'm gonna let you go off on external focus of attention.
Okay. Yeah. Well. Yeah. I mean, the external focus stuff is one way to do it as well. I mean, I'd also argue that you can do it with autonomy support if you like you mentioned, so to give choice on different, when to do what exercise. Obviously, choice needs to be under your sort of predicament in terms of what's good for them and stuff like that. But choice can be whether it's applicable to the actual task or not. I mean, you can even go as far as like rest periods. I mean, I think just having that control is really important and allows them to again self-organize, like we mentioned. And then I think other ways is obviously external focus, right? Concentrating on intended movement effects, not really your body movements per se. And then I'd also extend it to confidence. And I think this whole enhanced expectancy sort of debate is if I feel more confident in what I'm doing, my motor system is going to be much different than if I feel very not confident. And I mean, when I tore my ACL and went through rehab, which really sparked my interest in motor learning in the first place, was just I felt stuck at moments, right, when doing exercises and being told how to do certain things, and other times I really felt really automatic in a sense. And so clearly there's something going on with the external focus and the confidence and all that. So I think those are easy ways. So I mean, like I mentioned, so external focus is just changing how you instruct and give feedback. Autonomy is providing a sense of choice. And for confidence, are we making the skill, are we sort of really harping on the success rather than sort of like the unsuccessful portions of rehab? So that's just a little introduction to that. Yeah.
I'm a little bit more biased on the cognitive component. So you've just nailed the motor learning components of that, like exactly what I would suggest in early rehab. But for me, if you're working on straight leg raises and stuff like that, there's no reason why this person needs to just be thinking about their quad activity, especially if you have them hooked up to NMES or something like that, where they are being cued by the unit to contract. So there's no reason why we can't be adding like these sorts of cognitive demands as we talk about in there. Also, I think just manipulating the way you do your exercises. So Harjiv touched on blocked practice. We do 3 sets of 10 quad sets, then 3 sets of 10 straight leg raises, then 3 sets of 10 whatever. And manipulating your treatment session to be more variable and to not only do a blocked session of every single exercise only like keeps your patient more engaged, but it's really good for their learning long term in all of those skills. So I think just being mindful overall of how you're organizing your therapy in the acute stages can be one of the most important things that you can do to implement these sorts of strategies.
Yeah, one thing I'll just go off on that is you mentioned like blocked practice and stuff like that. One of the I think I'd probably term it as a misconception is like you can do 3 sets of 10 whatever exercise, but you can also make that random. And like Meredith mentioned, it's a very continuum sort of thing. So I can go blocked and constant where I'm doing the same task variation. I can do blocked and variable practice, right, where I'm doing different variations of the same exercise, or I can just go completely random, right? So it's like this continuum where you can follow, and I think it can be really easily implemented in the acute phases of rehab. So
now I wonder if you could write like a program, if either of you are coders, where you basically put in all the tasks you want done for that session, and it can rearrange it. You click a button and it randomizes the exercises for you, so you sort of takes the pressure off of just ticking all the boxes in that day in the clinic.
Just use a random number generator online.
So well, there you go. Let's make it an app.
Yeah, I'll say this: we're working on something, and so hopefully soon it'll come out.
Okay.
But yeah,
how do you change your language, your metaphors, your cueing for different age groups? I know that lots of different age people tear their ACLs and have different backgrounds and understandings of things that may influence how you talk to them.
Yeah, I think number one is that you want to really take that whole patient-centric approach, right? Know what their preferences are, know what they like, what they don't like, get to know them as a person, right? At the end of the day, you're spending so much time with them, and that will shape how you cue, right? What if if your patient is an older gentleman who likes to run, right? Like all of your cues should be related to things that they like. And so, I think that's the number one thing. I think you need to really, the cues need to be number one, related to the task. Number two, challenging the motor skill needs to be challenging enough for them for these, external focus and metaphors and all that to work. And all those instructions should be catered towards what your athlete or patient enjoys to do. So that's what I'll leave with that.
I like to fall on the end of the spectrum where I try to make things like funny. So like one of the things that I would do for like landing for a depth drop, right? If I want somebody who's landing like with really wide feet or something like that, most people have played Mario and they understand that Mario jumps into his little green tube. So I'll say to a young kid, I'll be like, hey, I want you to be Mario and I want you to jump into your green tube, okay? And so that adds a little bit like fun character to it, gets them to at least picture something else while they're doing it. Might not follow strictly Harjiv's framework, but that's how I would maybe regress my environmental constraint or attention to the task for a younger individual versus, using foam rollers or like other sorts of environmental tools for that individual.
So we should really be keeping up on our TikTok trends so we could reference those in the clinic, huh?
It's a good idea. I'm not gonna lie.
Yeah. Okay, I got a nice long question here. I'm just going to read it to you, and I'll let you guys answer. How do you best help the individual to appreciate the goal of the task without directly verbalizing the goal, particularly if the individual has minimal to no previous experience with the task at hand? Do you use the contralateral limb as a reference point for the individual to have a sense of what the movement should feel like, and then manipulate various constraints in an attempt to achieve optimal strategies? Or how exactly do you build a framework for them to understand? In regards to using the contralateral limb, I could potentially see the two flat tire analogy applied, but in the sense of functional strategy versus an isolated capacity.
That's a loaded question. I don't know that I remember all the components of it.
Let's start with the first one. So how do you best help the individual appreciate the goal of a task without directly verbalizing the task, particularly if they have minimal to no previous experience with the task?
I'll just say one thing. I think they should be aware of the goal of the task. Yeah. They should know what the goal of the task is. The question is, how are you then, doing your rehab so that they can achieve that goal of the task? So they need to be aware of their movements and the goal of the task for sure. But it's upon execution, what do we do?
I think the issue that comes arises in therapy, a lot of the time the goal of our task is to exercise. So the goal of a squat is a squat, right? But in motor learning, we might say the goal of like the squat jump would be to get the rebound. So I'm going to tell the person get the rebound, right? And they're going to use their mechanism of a counter movement jump to do that. But if I, in therapy, just say we're going to do counter movement jumps, then they think that that's the task goal. So sometimes for your exercises, it's manipulating that the exercise isn't the goal. It's whatever the external goal, the movement outcome is that needs to be focused on. That would be grabbing the rebound or, going around the cone with a cut, those types of things.
Okay. So the second part of the question, which I think you just answered, which is, do you use the contralateral limb as a reference point to have a sense of what the movement should feel like, but and then manipulate various constraints to achieve an optimal strategy? But I suppose what you just said is true, is that you're not they should know what the task is. They should know what the goal is. And if you're just teaching them an exercise on one leg, you're just showing them what it should feel like, not necessarily giving it a broader context. Am I right?
Yeah.
Sorry, I'm not.
Yeah, I'll add to that and say, if we go back to the whole bandwidth approach, you can, in terms of like the constraints, you can start the task in different ways, right? Change if you're starting on your contralateral limb or your actual, the limb you're working with, what range of motion you're starting with, the time limit, the distance of the cones. I mean, you can just change it up after every repetition. That would be, because you're at the end of the day, you're achieving this functional variability, right? They're allowed to, they can achieve set goal through many different ways, and that's the goal essentially.
Yeah, I like that question a lot. I mean, it's someone who's trying to understand this stuff, and it's not that easy.
So I think too, like we've just given examples of like intermediate to end stage, right? Rehab. But what I'm thinking about with this is actually like my 15, 16-year-old athlete who this is their first major injury, is their ACL injury, had reconstructive surgery. You're seeing post-op day one, and they can't do a quad set because they have inhibition, right? So they've never probably sat there and thought about squeezing their quad before, right? Or doing a straight leg raise. They don't know what the goal of that task is. So in that, I definitely would use the other leg to show like this is the goal of what I'm trying to accomplish. Okay, now let's do it. Now show me how you do it on your injured leg. Yeah. And so I think in those instances, especially acute, it can be necessary to have to know exactly what you want to get out of the exercise.
That's a good very clinical example. So is one solution to this whole problem to get athletes back on the field as soon as possible, starting with rudimentary skills in a progressively chaotic environment? The complex systems approach is kind of built in when you do this, right?
Yeah, in a sense, yeah. However, but I would say like you want to shy away from the approach where you are like stripping away perception and action. Um, like in the beginning of rehab, and like mentioned in the blog, you can do a straight leg raise to maybe like a soccer ball or something, right? That there's something there that's maybe related to whatever the person is doing. And then you add things like VR and all that stuff later on, or stuff like that. But it's I think it's also important to mention that like we talked about representative design in the blog. That's very different from ecologically valid. Uh, so I think clinicians should really take notice to that. Is it's not just doing what's game like, because anything can be said to be game like at the end of the day, if you look at it through different lenses. But I think representative design is am I taking the perception and action apart or together? And I think that's where this idea of progression should be really looked at in that type of lens. But Meredith, I think this is a better question for you.
No, I think that I agree with everything that you said, and I think that's a perfect response. And I mean, my goal honestly is not to return athletes like back to sport faster, right? That could be a misconception of this theory.
Yeah.
The goal is to challenge them in multiple ways, both from like muscle strengthening and cognitive processing at a level in which might mimic sport, right? So what can I do in the clinic that challenges these processes to create motor control under a cognitive demand like it would be in sport, or can I recreate the physical demand in the clinic that they're going to experience when they get out on the field? And I think that's overall the goal, acknowledging that clinics don't have a lot of resources most of the time, right? So we're trying to provide almost like it's not really a framework, but like strategy that we can try to get the most out of your session with very little resources is kind of the goal of this. So I think it's just overall, how do I challenge my athlete at the muscular and physical and cognitive level to maintain good learning and motor control versus get them out on the field faster.
Yep.
Okay. The next, there's the more clinical questions. How could you encourage movement degeneracy with a simple lateral cutting task? What constraints might you manipulate? Can you walk us through this?
Meredith, do you want to do that? Or I think we hit on it a little bit already. It's I'd argue that like when we talked about constraints-led approach in our blog. I think every patient should have their own CLA profiles for the situation, which kind of harps on what you mentioned in terms of the app situation. We're getting there, so hopefully soon it'll be out. But I think for lateral cutting tasks, say the idea is to cut right. You can change distance of the cone, change starting positions, change different effects. So like outcomes, right? Am I cutting to a soccer ball, stuff like that. So I think that would be a good way to do it. And then obviously you're looking at maybe the way they're cutting, the knee angle, whatever it may be. But yeah, Meredith, that you can take
what they're looking at.
Yeah.
No, I think that's perfect. I literally have nothing to add. I thought that was great.
Yeah. So movement degeneracy is like generalizability. That's how I think of it. Am I about right on that? Can you do this task in different contexts?
Yeah, essentially, can you accomplish a set goal different ways? Yeah.
So some baseball players are really good golfers, but some baseball players are terrible golfers. Why do some people just have it? Do they just translate kind of a similar motion to other applications better than others? Is that a thing that interpersonal variability?
Well, I think so. Movement degeneracy is actually like a biological phenomenon, right? It's really hardcore biology. So yeah, I think between person variability is huge because I mean, take an example of like if Meredith was in front of me walking in snow, I would never be able to exactly copy the same steps that she's doing. It's just never going to happen. And I really encourage you to go try it. It's just not going to happen. So I think the between person variability is very prominent. But at the same time, movement degeneracy doesn't really refer to transfer between sports. I think those are more in this realm of study is more called donor sports, which is not the goal of our blog. But movement degeneracy doesn't really refer to like between sports. It means that I can again achieve that same goal to different movements, and so I think that's a good definition to have, and it's within that particular skill that you're looking at. So.
Okay, so this doesn't necessarily refer to similar movements with different goals. It's similar movements with similar goals, different contexts.
Same goal, different movements. Yeah.
Okay. All right. That's why I'm such a bad golfer. All right. So if an athlete gets exclusively linear rehab, is there a point of no return where they won't benefit from a more complex systems approach? I think we've all inherited patience, and Meredith probably sees second opinion or 1 year out ACLs that are still struggling.
I think that this is such an interesting question. And honestly, I don't know the answer if there's a point of no return or not. Like there's the research isn't there. But what we do know is that the rehab that we prescribe now is pretty much exclusively linear. Like we're focused on getting range of motion and strength back, and whatever our motor control or functional performance might be, return to sport on these very linear metrics of hop testing and strength. And we see quite a big re-injury rate, up to 34% or higher sometimes. A lot of injuries occurring in the contralateral extremity, but then in some studies, up to 60% of people not ever even returning back to their prior level of sport. So to me, all of those factors together kind of say whatever we're doing linearly might still be suboptimal for our patients. And so even the best therapies right now does not mean that you're going to never sustain a second injury. And that's devastating to a clinician. It's really devastating to the athlete. So I don't know the exact point of no return answer. I gave a pretty morbid answer to it, but I think that it's something that we need to consider as far as how we employ our rehab. And I think that's where the field is kind of pivoting, is to how can we better integrate the factors that we aren't considering in our traditional care.
Yeah, and I think just to add on that is like, no matter what approach you use, learning is still going to happen. You're still going to get better at whatever, because you're doing it more often. It's, is the person able, again, the goal of rehab, right? Is the person able to transfer that to the playing competitive field effectively? And so that's where sort of the shift in like, it's not a cause and effect, but it's an interaction sort of perspective comes into play. But again, no matter what methodology or what approach you choose, learning's still going to happen. They're still going to get better at what they do. It's just, are they going to get hurt or not? Again, that's the goal in question. So.
Well, that's encouraging. Yeah. How do you reconcile your neuro work with an ecological approach? If the environment dictates all, then why do we care about what the central nervous system is doing?
Okay. I think I know who asked this question, but we'll talk to them another day. Essentially, so the way I was looking at it is like the blog, we kind of took more of a dynamical systems approach, which as opposed to an ecological approach. Obviously, they're really interrelated, but dynamical systems has a heavy neuroscience and mathematical component to it. Now, for ecological psychology, it's not that there's no care to the central nervous system, but rather the role of the central nervous system is completely different. So what we know of as the nervous system is like something like a signaling or a communication sort of system connecting. You have sensory inputs and you have motor outputs. An ecological perspective really looks at the nervous system in terms of simply for the use of motility, which is sort of the muscular contraction-based motility of these large, macroscopic variables. But the thing here is, and it's ecological psychology for a reason. A lot of their reasoning is from animals, like actual animals and how they've evolved and stuff like that. So I think it's just a shift in thinking about what the central nervous system actually does. Now, again, it would be really interesting, and there's no research in terms of what I've looked at, to look at the effects of the ecological approach on brain activity. I think that would be super interesting, just to see what's going on. But yeah, I can send you some papers I read this week, and I think I know who asked this question, so I can just send it over. But yeah, Meredith, if you have any.
No, I thought that was great. I think that it's tough when you look strictly, like Harjiv said, at ecological psychology. They kind of mitigate cognition. They mitigate like your role in it, and you essentially conform to your environmental constraints. But we know that we're able to plan movement. We know that there's these neurologic factors that don't necessarily abide by this sort of philosophy. And I actually randomly listened to a podcast, and I ended up looking up this article today that there is a group, I forget what the lab is, but there's a group that's utilizing dynamical systems in like AI. And I thought that was really interesting because I had never even thought about that. But they are making like artificial neural networks based off of the dynamical systems approach. So I don't know enough about it to like really hammer it, but it's something that I thought was super intriguing.
I'll add to that and say, so coming from like we are doing philosophy degrees at the end of the day. I think thinking about it in terms of philosophical terms, what does cognition even mean, right? I mean, cognition is simply a name for processes like attention and memory and all that, but they're just affective responses in the central nervous system. So I think it's important to challenge these assumptions, and I'm not saying that I'm on one side or the other. I think it's important to challenge, especially clinicians who are applying it and other theorists and stuff like that, is like, what is technique, right? What is cognition? What are we actually doing, right? I think that's sort of what gets me up in the morning, but that's just, yeah.
I love it. Well, this next question kind of makes me laugh. So does this explain why some strong athletes get hurt? I keep seeing the problem in PT is lack of strength training. Makes me think there's more going on. What do you think, Meredith?
So my short answer is that usually the strongest athletes aren't your best performers, right? Like, I don't know that you can look at like the NFL combine testing. I know Dr. Grooms goes off about this all the time, but like lifting really heavy things doesn't mean that you're going to be successful in the NFL. There's zero relationship between those two things. So I think it comes down to we need a better way to analyze athletic performance based off of motor coordination, motor control, than the way that we do now.
Yeah. And just to plug in there is Rob Gray had a recent podcast on action capabilities. And so I think definitely take a look at that. But the idea was like, that the whole goal of strength training is that you improve action capabilities, and so that will effectively change how one interacts with their environment. But what we do is we just take the environment out of the equation. And so now it's just strength aspect of it. And I think that, it's a tough question, but I think it's also, I think strength training is just really changing, our capability to perform, and that needs to be taken a look at a little bit more.
I feel good saying this, but I just took a sports metrics course, and Dr. Frank Noyes talked to us, and he's like the nicest guy. You probably know him, Meredith. Maybe your neighbors, I don't know, but he did say that their numbers, their retail rates are really low, and I would be curious are you aware, just kind of because you're in that world, you're in that part of the world too, like physically close. Ohio seems to be quite the musculoskeletal hub, but just curious to know, like, is there some secret sauce that some programs are doing? Look, I'm wearing a sports metrics shirt right now. Are those, like, is there some secret sauce there that we should all know about?
I don't know. I think this is like a huge debate in injury prevention programs, is like anytime you do exercise, right, you're training the neuromuscular system. Your first 8 to 12 weeks of strength training is neurologic, right, before you tap into the muscle gains. And so I think when you train and you train consistently, you're going to get good results. And I think that's what we see consistently across injury prevention programs, whether it's sports metrics or the 11 plus. I don't know, right, if adding some of these other factors, cognitive overlay and such, would augment those that do get hurt, right? We see a lot of research now coming out on like visual memory capacity and visual motor ability being related to an individual's injury risk, whether that's after concussion or at risk for ACL injury. And so that's probably the component I'm most intrigued or interested by, to see if we can augment like a sports metrics or 11 plus with more of these interventions. But I've never honestly taken the sports metrics course, so you would know like if they do neurocognitive interventions in it or not.
Yeah, I mean, it's basically it's a very solid 6-week jumping program, plyometric program, and there's a lot of heavy focus early on technique and landing. I mean, they spend more, the focus is more on landing than anything, and they start with a very, you have to have a very good technique for that first week, and then they progress you a little bit, and there's kind of 2-week phases. But I will say in the last phase, the 5th and 6th weeks, I mean, they do encourage talking about altering your vision. They talk about using the strobe glasses and things like that, and so there is some progress. But it just, I mean, to me, I was really struck, like it's so simple, which is good. I mean, I think, more than anything, adherence to the program is going to give you the most bang for your buck with the athletes, just getting them to do the training.
Can I ask one question?
Yeah.
Sorry, Meredith, I think you were going to say something.
No, I was just going to say I'd be interested to see like how exposure and what level of activity returning to that's offered.
Just like as clinicians, and this is just kind of a question that I've always had, is like, we kind of, like you mentioned, Matt, like towards the end of that program, they started, altering vision and all that stuff. What are your thoughts on that complexity and kind of, catering that complexity or scaling it to the beginning of rehab? Is that a possibility for the work you guys do? This is just a general question. Like, to make it complex in a sense, right? Not to make it so like it's just, again, technique and then complex, but like complex right away.
Go ahead, Meredith.
Oh, you want me to answer that? I was liking how he was putting the question back on the host.
Yeah, I know.
Oh no, this is to anyone.
So no, I think that's the point of like what I'm interested in, right? Like if you know the skill already, like can I augment my traditional therapy with this complexity, right? I think that's the entire goal, especially with like strobes, is like, okay, I have this somatosensory insult. I need to downweight my visual input, right? And try to focus more information on somatosensation to produce an output. But go ahead, Matt.
Yeah, I think I probably heard Dusty talk on this the most, and he always has some really simple, practical examples of using, an external focus, like early on day one, laser pointer on the shin, things like that. Be really easy to set up PowerPoints, and so I think getting that kind of stuff going really early is not hard, although it is sort of outside of what we think of as, I would say like your typical clinician might think of as a treatment pathway. You don't really think, you don't always see people breaking out the strobe glasses on like post-op day 3, but not a bad idea. So, so I think we could probably be close to wrapping up here. We've covered pretty much everything, but I would like to know, I'm a clinician. There's hopefully lots of clinicians will watch this. Where do we start? Like, let's say this is a new concept to us. How can we make an immediate impact? How can I walk into the clinic tomorrow and start implementing some of these things now? What are some practical tips you can give?
I think for me, being mindful in how you employ your interventions, right? Like step 1 is self-reflection on you as far as how do I currently practice? And is it by giving people a lot of cues all the time? Am I constantly telling people what they do wrong and not what they do right? Or can I give people 3 different quad exercises, and I know I want to do a certain quad strengthening exercise, but allow them to choose one, right? And start at very simple aspects of how I practice to provide autonomy to my patients and maybe adjust how I'm cueing and giving instruction to them. And then I think from there, you can layer on your cognitive aspects and get more in depth with it, or just practice like, hey, a few patients a week, I'm going to get in the mode of making my entire session variable. Like I'm not going to do a blocked practice for the entire thing. And it's almost like graded exposure for clinicians, right? Like I don't expect this to be like an immediate jump and you're able to input all of this stuff at once. But it's more of, for me, it's a reflection on how you currently practice and pick the things that you think you can make an impact on first, that are not detrimental to your time you need to document, that your time that you have, if you have multiple patients at once and such like that, those are all factors to consider. So that's where I would start for these.
Yeah, and I would agree 100%. I'll probably just add like you mentioned, Meredith, the whole instruction stuff. Easiest way is to record yourself over 1 or 2 sessions and see what you're saying. I mean, that can give you such a big, like it can open your mind to so many things. That's probably the easiest thing you can do to kind of really keep it patient-centric, not I'm the one in control. It's that they are the one in control. And then, we talked a little bit in the blog about representative design, and I would say, try to understand movement behavior, not just the outcome of what you're seeing. And that ontological shift will really allow you to become a better clinician. Now, I'm not a clinician, so I may just be kind of saying things that don't make sense, but and again, I can clear it up just by talking to someone. But I think that's a good sort of perspective. And then what we ended the blog with saying was like, you allow your patient to sort of create these movement problems for them, not just solutions. So that's, I think, another shift in how we sort of do rehab is important. But yeah, that's what I would say.
Yeah, I think that's huge. That the idea of giving someone a movement problem to be solved with, and then they can figure out their own movement solution. I think that's really that's some good language. Is there an infographic that people can reference with some really clear, practical
Yeah,
techniques. Yeah.
there is.
Yes, it came out. It came out today, didn't it? I'm going to put the link to the infographic that we worked on here. So hopefully lots of people will click on it. But I thought that was a really fun thing that we got to do, and appreciate you guys humoring me in putting that together. I think that was great. So if you don't know what I'm talking about, if you're watching this, you don't know what I'm talking about. We put together an infographic and on some practical ways to augment your rehab with a complex systems approach, constraint-led approach. Sorry. So and it's good stuff, and it would look nice on the wall in your clinic.
It was awesome. Thank you for doing that, Matt.
Yeah, thanks for that.
Yeah. Is there anything like you would want to share with us that we didn't talk about? Is there anything that kind of comes to mind and says like, oh, I wish we would? Now's a chance if there's anything else you wanted to talk about, get off your chest.
No, I think this is great. I think rehab is definitely getting there, and I'm just glad to be part of the motor learning end of things to kind of really help bridge that gap. Like I said, I'm not a clinician, so what you guys do, you're great experts in it, and I just want to help any way I can for the sake of your patient. I think it's an exciting time to really kind of take these two different arts and bring them together. So I'm just glad to be part of this, and thanks for inviting me.
Yeah, well, we're happy to have you. It's great.
It's been neat to be on the clinical end of things, and then now starting to get more ingrained in the research end of things, to watch the two worlds come together in what I would think is a very short amount of time for this kind of stuff to catch fire a little bit. There's a lot of interest. And I think that step one is being curious and being willing to try to learn and just be open to new things. And so I'm thankful for everybody who is, and it's sharing their knowledge and attending these sorts of webinars and such like that is fantastic. So thank you for the opportunity, and thanks for having us. Yeah,
this has been super fun. I really like this a lot. I would before we sign off, I just want to remind anyone who's watching that this is the second in a series. So I actually have 6 more of these coming, which I'm just really excited. I got all these people to agree to participate. Everyone's been so generous with their time. I really appreciate it. Next up is Dave Sherman, and he is going to be talking about some really cool stuff. I can't sum it up in one sentence. It's pretty heady, but it's really interesting stuff. And it's kind of in the similar vein of today's and last week's, or 2 weeks ago with Dusty and Lindsay, kind of neurocentric. And I think it's going to be really, really fun read. So Meredith, Harjiv, thank you so much for taking the time to write the post, answer questions, and that's about it. So really thank you, and have a great rest of your night and week.
Yeah, thank you.
All right, bye.